Our next topic is thyroid disease, hypothyroidism. Our case, a 23-year-old gravid of 1, 30 weeks gestation, has lost 4 pounds over 2 months. Pregnancy is not a time to lose weight. This is not normal. You should be gaining weight. She states her heart is racing and her pulse is 135 a minute. Now, the heart rate does increase with pregnancy, but not to 135. She has a noticeable tremor when she holds her arms out straight. Now, I did not make up this case. This is a real case that I had, and I was so excited. Here I am, an obstetrician gynecologist, making a diagnosis of hyperthyroidism. That's normally for internal medicine folks to do. Her eyes appear prominent and protruding. And this is not uncommon with hyperthyroidism in pregnancy is contractions and preterm labor. If it is uncontrolled, not good, poor outcome. But hyperthyroidism properly controlled will do generally quite well. Thyroid storm, I'll leave that to the internal medicine people to talk to you. That is life-threatening. The most common type of hyperthyroidism in pregnancy is Graves' disease. When we look at the pathophysiology of Graves' disease, it is basically thyrotropin receptor antibodies, which are autoantibodies produced by the patient, which stimulate the thyroid gland independent of TSH. The diagnosis is made by a low TSH, a high T4, and increased TSIs. In terms of therapy, we have medication, surgery, and radioactive iodine, 131. Clearly in pregnancy, medication is preferred. And most patients we have on PTU, propylthiouracil, blocks T3, T4 synthesis. Methimazole also has been used. Very commonly, we have to increase the dose as the pregnancy continues because we want to maintain it in a therapeutic range. We want to keep the patient in high normal. We'd rather not oversuppress because we don't want to get excessive levels to the fetus. Surgery is used only if medication fails, and I must say this is very, very rare. Radioactive iodine, 131, never used in pregnancy because it can cross the placenta and ablate the fetal thyroid, which we certainly don't want to do. This is a patient of mine who had Graves' disease. Would you say she has a prominent neck? I think so. How about on this image? And do her eyes stand out a little bit? Perhaps. She was well controlled and did well. Now, hypothyroidism, the effect on reproduction. Many patients who are hypothyroid, do not ovulate. And if you don't ovulate, you're not going to get pregnant. Infertility, one of the tests that we will do with infertility is check for anovulation. If untreated, and if she does conceive, spontaneous abortions are more common, miscarriages. But if treated, normal pregnancy. And I have many folks who come to me who are on thyroid hormone because of hypothyroidism, and they will do well. Management or diagnosis, we look for a high TSH, and the treatment in pregnancy is thyroid replacement. You want to maintain and, in fact, even increase. Probably throughout the pregnancy, I would do a TSH every trimester, and you're probably going to end up by increasing the dose by 50% or so. And that is the end of thyroid disease in pregnancy.